associated injuries. Okay, we'll go into those. And then peritonitis after blunt trauma, right, is very rare. But it does signify that a possible rupture of a hollow organ, meaning the duodenum, the bladder, intestine, gallbladder, pancreatic injury, or we have any presence of that peritoneal blood, normally we'll go in. Okay, this should not be new, right? It's just the overview of the HRP. We want to know that why, right? We want to know whether it was blunt or penetrating, or a combination of the two. You know, an MVC shows different injury patterns than a fall, than a gunshot wound, than a stab, right? When was it? Was it 24 hours ago? Was it last week? Was it 30 minutes ago? It all depends. It definitely changes your algorithm, whether it was 30 minutes ago and they're, you know, unstable versus a week ago and now unstable. Now, you know, a week ago, remember that injury timeline, right? If you're unstable after a week, most of the time it's sepsis, not necessarily due to the trauma, but the complications from that trauma. Okay? You have that missed report from EMS. Okay? We do that primary and secondary survey. Now remember, when you're doing the primary and secondary survey, a lot of the stuff's happening at the same time. Right? It's not necessarily one thing after another. It's sometimes it is, but most of the time all of this stuff is happening in conjunction with each other. Alright. So, auscultation. The presence or absence of vowel sounds does not rule in or rule out intra-abdominal injury. Okay? Does not. I don't even listen to the belly when I have a trauma that comes in for a primary survey. Okay? Because their body is in a shock, adrenaline state. Their belly is probably not getting blood, right? Their body is in that fight or flight response, and their blood is the body's trying to compensate, getting blood to the brain, blood to the heart, blood to the lungs, right? So the bowel is like this secondary type of effect, and it's you're not going to necessarily hear vowel sounds. So absence of vowel sounds does not prove that they have an intra-abdominal injury. Okay? But having vowel sounds does not necessarily mean that there isn't an injury. Right? Right? So this is the one real case in which, like, you don't have to necessarily listen to the belly. You listen to the heart and lungs, but not necessarily the belly when we have an initial trauma patient in our primary survey. Okay. Ileus can be caused by a whole host of things. Okay, so it really just depends on what's going on. When we do percussion and palpation, okay, we're listening for dullness versus hypertympany. Okay, we want to listen for whether or not we think the belly is full of blood or fluid versus air. Okay, making that differentiation definitely, you know, will kind of help lead you into what algorithm we're going to go down. Okay, when trauma patients will normally say that they hurt all over. Right, they've just been hit by a car, or they just fell. Right, they're in pain kind of all over. The global sensation of pain. We can't really, especially in that first, you know, fight or flight response, their brain is like, I just need to get out of here, I just need to do whatever. It's not really sending those signals of what actually hurts where. Okay? So we try to ask them questions and try to look for, you know, to differentiate between like abdominal wall pain, back pain, is it visceral pain on the inside? We're really trying to ask them, you know, all of these questions to try to differentiate like what type of pain they're actually in, okay? And helping and, you know, looking for these other intraperitoneal injuries or signs of those injuries is very, very important. The seatbelt sign is the biggest sign that I've seen. You know, I haven't really seen Gray Turner, I haven't really seen Cullen sign, but seatbelt sign all the time, right? All the time, and that definitely is something that we use on a daily basis that says if you have a huge ass bruise 30 minutes after your car accident, either across your pelvis or across your chest, you experience significant trauma. And we have to now do more things from that. Right? So that's definitely one that if you see a seatbelt sign, know that you have to do more. Okay? What labs are we going to get? Again, we kind of do a rainbow. CBC looking for that hematocrit and hemoglobin. We want to do a CMP. We don't want to necessarily do a BMP here, right? Because we want to know that kidney stuff. We want to know the liver stuff, as well as the electrolytes. So BMP is not going to be sufficient here. We have to do a CMP. Okay. If we really suspect, a liver injury, doing additional liver enzymes may be needed, but most of the time, at least getting the AST, ALT, ALK-Phos, and bilirubin are going to help kind of differentiate between the liver and something else. Okay. We also want to know what their BMN and creatinine is. Knowing what their initial baseline, before their body really has the chance to compensate, right? If they have a creatinine of 2, that may be their baseline, right? They may already be in a stage of, chronic kidney disease, versus if their BUN on admission was 0.9, and now day 2 they're at a 2, right? We probably didn't resuscitate them enough. Right, we use those baselines as a way to kind of guide our treatment from day to day. But if we don't have that initial baseline, it's very hard to say, okay, day 2, now we're at a creatinine of 2 or higher. Like, well, what is their baseline, right? What were they on admission? And if we don't have that, we have to do a lot more investigation. That costs money, and we try not to do that. Doing a UA, looking for blood, protein, ketones, all of the things, okay? Beta HCG, either blood or urine, okay? If they can do urine, cool. If they can actually pee, or we put a Foley in and they can give us urine, then we'll do the urine tox. We'll do the urine HCG on the female. If not, we'll just do the blood, especially for a female of childbearing age. And we know that they're in a bad way, we're just gonna do the blood HCG. Any special tests? Okay, the blood typing, a type and screen is a normal one that we automatically do. Okay, it's very fast. If we think that they need to do blood, we'll add on the type and cross. Okay, that's more specific. Amylase and lipase if we suspect a pancreatic injury. ABG, VBG. Normally we'll do an ABG if they're really critical. Okay, and then a blood alcohol level and a urine tox for everybody. Okay. Imaging, we already talked about this. Okay, chest X-ray, these are some of the things we're looking for, right? These are the things that potentially could kill their facets. Lower fractures, not so much, but if they're, I've actually seen a chest X-ray where we had a rib fracture. It was so pronounced angulation, it was actually into the chest versus around the chest, right? So knowing what those look like initially, can definitely help. The abdomen ultrasound, knowing if there's hemoperitoneum or pneumoperitoneum, or at least hydroperitoneum, some sort of fluid in the belly. Okay, and then pelvis. We're doing those ultrasound, or we're doing ultrasound with the FAST, and then we're doing the pelvis X-ray, looking for those fractures, looking for bladder injuries. Okay, so we'll go through those. CT. Okay, so definitely has limitations. Can miss those hollow viscous injuries. Okay, but if we see any signs of fat stranding, if we see any signs of pneumoperitoneum, even if it's a tiny little blip, we're not going to necessarily take any chance with that, and we'll at least do a diagnostic. And if we see injury or blood, then we're going to zip open. Okay, but you have to understand that delays in diagnosis really increase morbidity and mortality. If we miss even just this little thing here, right? These are 2 tiny little enterotomies, right? 2 tiny little holes in the small bowel. But if we miss that, right, there's going to be succus and fecal material coming out of these holes, and they're going to end up with abdominal sepsis and be very poorly, greater risk of dying. So we try not to miss things. Okay, so when we talk about blunt, again, hollow viscous injuries, serious consequences if diagnosis is missed. We're looking for abdominal tenderness or any tachycardia. We also look for distracting injuries, right? If they have a femur fracture, you know, then we have an even lower threshold to do a diagnostic lab for any signs of abdominal injury, because they're so focused on that femur fracture that they may not even notice that they have abdominal pain. Right? Again, that seatbelt sign. Okay. Really more than double the relative risk of small bowel injury. Okay. Having that seatbelt sign also increases your risk of having the flexion distraction fractures of the spine. Right. And if you have a fracture of the spine, say you see the spine fracture first, then we have to have that high suspicion of a hallucis injury. Okay. All right. Not uncommon to have a latent period with blunt abdominal trauma. Okay. A lot of times, like I said, they're in that fight or flight response. They are not really thinking of, you know, they're just in this global pain, or, you know, they're distracted with that femur fracture or whatever. Okay. Those two small little holes, right, probably aren't going to cause peritoneum or peritonitis right away. Right? They're not going to necessarily have that succus go through because the valves probably aren't really working efficiently because all the blood is going to their essential organs. Right? So it's that over that next 24, like really 72-hour mark, that this is why we admit people with seatbelt signs who are stable and really no belly pain or very mild belly pain, right? Because they have this latent period. It really, their belly needs to have time in order to mount that inflammatory response to then show us peritonitis or show us changes in the labs of either a white count or a lactate level above 4. Okay? So these people will be admitted and we do serial abdominal exams every 4 hours. Right? And so trying to make sure that we try to pinpoint, you know, if they actually have a hallucis injury or not, and whether or not we need to go to OR or not. Okay? So latent period, very common. If it is a low risk mechanism of injury, right? They're going, you know, 15 miles an hour in a car, or they only fell in the ground level fall, you know, not really that high impact. It's a very low likelihood of it actually having a hallucis injury, right? So if it's a low risk mechanism of injury, they fell off a scooter, right? They didn't get hit by a car on a scooter, they just fell off the scooter. They weren't going very fast. They have a reliable exam, they don't have any head injuries, right? They're with it, they're not drunk, they're not high, but if they have a normal physical exam and normal lab results, more than likely they're just fine. Okay, so that's why we need to know what their mechanism of injury was and how fast they were going, to really know if we can have that reliable physical exam. If we don't have a reliable physical exam, even with normal lab results, it throws out low risk, right? We need to have that reliable physical exam for them to be able to tell us, my belly does not hurt. If they're drunk or high or confused or, you know, altered in any way, we do not have a reliable physical exam, and we're forced to do this expensive, you know, head to toe workup. Okay. Any signs of abdominal complaints, right? Any abnormal or unreliable physical exam, like I just said, any abnormal lab results warrants further evaluation. Okay, we either do a CT scan, and if the CT scan is, you know, equivocal, inconclusive, then we admit them for serial abdominal exams. Okay, and hopefully they will present themselves one way or the other. The next morning they're going to be like, yep, no, I'm great, I want breakfast, I'm hungry, give me some eggs. Or, man, my belly just really hurts, I'm not hungry at all. Their belly's a little distended, a little more rigid, you know, their white count may be up, then we know, okay, we need to go to the OR. Alright, so diagnostic imaging, like I think we already talked about this a lot. You know, we really rely on those ultrasounds, the fast exams, right, you know, up front. You know, right past the primary survey, we do the EFAST. We're looking for, you know, any signs of intra-abdominal fluid. Okay. If you see any intra-abdominal fluid in a hemodynamically unstable patient, that's, you know, we don't stop. We go straight to laparoscopy. Okay. Unfortunately, ultrasound does not distinguish between a hollow viscous organ and a solid organ, right? It's just there's fluid or there's air, right? So whether or not the patient is hemodynamically stable, then, you know, at that point, okay, do we just go to the OR, or, you know, because they have a lot of fluid in their belly, or let's go, because they're stable, let's go to the donut truth, let's get that CTM and all this, to see what we can see and maybe guide our surgical choices at that time. Alright. This is a long one. I'll let you guys read that. Before we actually get to the answer, because these type of long length synopses or vignettes kind of happen across all medical exams the rest of your life, who read the last sentence or the question first? Right? Who tried to figure out what is this question actually trying to get to first? Okay? If I could make a suggestion for those of you who did not raise your hand or are not paying attention, always read the last question first. Okay? Because it may be asking for what's the next step, or what's the next diagnostic thing, what's the next lab we want, you know, whatever we're trying to get to is in that question. Okay? Read the question first, and then go back up to the top, and then you can highlight the ones that are like, okay, yeah, they're talking about blood pressure, they're talking about, you know, whatever in the vignette, and then you can try to pick out, okay, they've already done that, they've already done that, they've already done that, this is the next step, versus going through the entire question and saying, oh shit, they want the next step, what's already been done, and you have to go back through the entire thing again. Okay, it helps you read them much quicker if you already know what the question is asking. Okay, because time is going to be your enemy when you get to phase 2. And these end of rotation exams are basically like 120 questions in 2 hours. That's a minute a question. Okay? There is no extensions. Right? It is a minute a question. So if you are having a hard time getting done with these exams, 50 questions in 75 minutes, you guys have to start reading these questions a little more intuitive, right? You actually have to see what these questions are asking first. Okay? So, what is the most appropriate next step in managing the patient? What's already been done? Okay, we have his MOI. He's been in a motor vehicle crash. He's in obvious distress. Alright? He's a little cold, but he's tachypnic, tachycardic, hypotensive. Venous pressure is diminished, sure. Neck veins are collapsed, sure. Breath sounds are patent though, they're present. Heart sounds are normal. Trachea is central. Semi-conscious. Pupils are bilaterally reactive. Okay, no obvious head injury. Abdominal exam shows distension, but tenderness in all 4 quadrants with muscle rigidity and guarding. Okay, we've already did the initial resuscitation of the airway, breathing, and circulation. What's next? What are we going to do? Who wants A, B, C, D, E? Double E's. Okay. We're going straight to XLab. Okay? He's unstable. Right? We've already determined that A, B, and C are nothing that we really need to worry about. So the next thing is we got to worry about his belly. Okay? So we are going to go to an XLab because he is shocking, right? He's already altered with a blood pressure of 80, right? And a pulse of 4. So what class of hemorrhage is he in? 4. Heart rate's above 140. Okay? His blood pressure is already shit. He's already altered. That's a class 4. Okay? That's automatically we go to XLab. I don't care what his imaging is. He's not gonna make it through the donut of truth. Okay, he's going to crash and burn in the donut of truth. So we go straight to XLab. Everybody understand that? Okay. All right. So let's move on to penetrating trauma. Okay. So you have a gunshot wound or a stab wound, and they are in shock, automatic XLab. Okay. We don't screw around. All right. Automatic XLab. With the exception of trans-genital wounds. Right? If they are a big guy or a big girl, okay, and we can do X-rays, right? This is the same patient, okay? We see that there's the bullet right next to his spine, but then we do a lateral. We're like, oh, well, it's real anterior to the spine, but it's still, you know, right where we don't want it, so it's going to be X-side, right? But say that the bullet is kind of like more so like over here, right? And it's like way up here in the skin or way out in the fat, right? When we do the lateral, it may be in the middle here, but if it's way out here on the fat on the AP view, okay, that's a trans-genital wound. It probably has not. It's just gone through the fat. It hasn't actually penetrated the belly. Okay, so. If it is a possible trans-genital wound, they only have one, and it looks like, you know, they have like 2 penetration wounds, and they kind of connect the dots, and it doesn't really look like it's gone through anything. That's when you can do the CT, especially if they're stable. They're most likely going to be stable, right? That's when we can potentially do a diagnostic lab. Look for that penetrate or the peritoneal penetration, and if it's violated, we can work to open. Okay. So if there's any, you know, any inkling of maybe this could be, we'll do a diagnostic lab. If it's violated, we'll open. But if we really can just connect the dots and it is truly outside in the fat, we do a CT and we can follow those air bubbles, you know, and the path of destruction. You know, nowhere near the belly. We don't see any we don't see any micelles on CT or X-ray, and we just have those 2 holes, right? That means there's 0 bullets, 2 holes. That's an even number. We didn't miss anything. Okay, but if we have 2 holes and 1 bullet, we've missed something. Okay. All right. So stab wounds, a little bit lower incidence of intra-abdominal injuries than gunshot wounds. Sometimes we do more selective measurement or selective algorithms, but like this, right? This. So if they have an actual, you know, instrument still stuck in there, then we're most likely we don't need to do diagnostic tests, right? Their diagnostic test is an XLab. Okay, we're not going to remove them in the ER. We're going to go straight to into the OR so that we can remove it, you know, surgically. What is this bottom picture? What is that? Not a potato.
Is the spleen coming out of them?
Not a potato. What do you think it is?
Is that a spleen coming out?
Is that spleen? It's small bowel.
Small bowel?
That's an evisceration. Okay, it doesn't look normal, right? But that is in the belly. Could be colon, but I doubt it. It's probably small bowel. Okay. So that, do we need to do any diagnostic with that? No, our diagnostic of choice is an XLab, right? Because we already know we can see bowel. There is penetration into there's violation of the parietal or the peritoneal cavity. Therefore, we do an XLab, right? We do not force those organs back in. Okay, we just cover them with a clean, wet dressing, and they go straight up to the OR. Okay, don't push those back in. Just like with strangulated, right? We want to evaluate that bowel before we push it back in. If it's through an injury, like a stab wound, right? Most likely it got stabbed and needs to be removed, and or it's been outside the body for enough period of time that it is non-viable and needs resected. Okay. And then with any stab wounds, with any hemodynamic instability, we just perform an next lab. Okay? Okay. So, any questions on penetrating? Cool. Alright. So when it's unclear, okay, if the stab wound has entered the peritoneum, right, or a little bit bigger, we don't have those obvious signs, okay, we can still take them to the OR or do this at bedside, depending on how bad it is, where it is. Okay, we can do a little bit of a local wound exploration, especially if they're anterior wounds, right? We have a little bit of that body, more body armor in the front than in the back normally. Okay, so we can do that local wound exploration. We can actually incise it a little bit more and try to get down to that base and see if it actually entered. If it did, then we'll do it next slide. If no, then that's it. We just clean it up. We leave it open to packing, and we, let them go home. Okay. We still try to insert an NG or an OG to decompress the stomach to avoid that aspiration. Okay, but again, don't put anything in the nose if they've had facial injuries until they've had at least a CT scan to see if there's a cribriform or a base skull. These are skull fractures. All right. So summary: blunt, no hemorrhage, no HPI suspected. We monitor, we treat, we do serial abdominal exams. We have a low threshold to take to the OR. Okay, but we admit these people, not necessarily to the ICU or step down, they're just on the floor, but they have a specific resident who goes and does their serial abdominal exams every 4 hours. Why wouldn't I want to have just random people going and doing this every 4 hours? You have a team of 6, right? Anybody could go up and do the serial abdominal exam, but why wouldn't I want just any one of those 6 going up? Why do I want it to be one person? Exactly. Exactly. They're not going to necessarily notice those small changes. They don't, one person to one person, right, unless they went with them, they don't know that they grimaced a little bit or that they had no pain or that, whatever those little tiny changes are from 4 hours from their last exam, right? So we really want the same person. And so when you go and do these turnovers in the morning or in the evening, right, you go with that new person, that new resident, to be like, okay, we're going to do a belly exam. You're going to do it, you're going to see what you feel, and then I'm going to see what I feel, and if I feel the same thing that I felt 4 hours ago, then you can be rest assured that the exam has not changed, right? But if you don't do that, you never really know whether or not the exam has changed or not, okay? If we see hemorrhages confirmed, great. Really depends on their hemodynamic stability, okay? Especially in kids. It really depends on if they're, when we'll get into these, like the liver and spleen and renal injuries, depending on what grade they are, really determines, if we need to take them straight to the OR or not. Okay? A lot of times, a grade 1 or 2, you may see fluid on the EFAST, but it's just a grade 2 or grade 3 spleen, right? And if we can save that kiddo from having their spleen taken out or having it embolized, like, we're going to try to let them heal. But if at any point it gets worse, then we go and do, the splenectomy. Okay. Any instability, right? Any instability, we go to the OR, and then watch for that latent injury presentation for penetration. If they are shocky, we go to the OR. If it's a tangential or a shallow wound, we do selective management depending on, what we see. And then more commonly it's a small versus large bowel that's injured. It just really depends on where it's at. There's more small bowel than colon, so small bowel normally gets hit more than the liver. Alright, when considering blood injuries to the abdomen, which of the following is the best expectation management counseling to provide to the patient? Which one is correct? What's A, B, C, D?
The rest.
B. Yeah, most blunt abdominal traumas is managed. Alright. Alright, so now we're going to specifically talk about the liver. Okay? Most commonly entered solid organ is blunt trauma. Okay, frequently involved penetrating trauma too, but because it's the biggest solid organ in the belly, it likes to get injured. Okay. So, in terms of non-operative management, we really try to, get the blunt, low-grade liver. We try not to do operations because it likes to just, kind of tamp on and fall off. And as long as it doesn't get any worse, we really try to, because we can't really take out the liver, right? Not like the spleen or not like one of the kidneys. We really can't take out the liver. We can take out part of it, but we try not to have to go in because, dealing with a blunt, like a fracture of the liver, trying to put it back together is very fragile tissue, right? It doesn't like to be held back together. So unless we need to go in and like pack it and try to, put compression around it with lap sponge, then we really just try to not have to go into the belly at all, okay? And then isolated right subcostal penetrating injuries. That one's hard because we still want to know if it's a diaphragmatic injury or not, but we try not to go in if they just have one injury. Okay, and they're dynamically stable. So stable and positive fast, we'll do that CT. Okay, we're looking for that IV extravasation. Okay, we're looking for any fat stranding, any air within the belly, trying to diagnose those hollow viscous injuries, and then the solid organ injury if we see this with active bleeding, we'll try to do angiography first. So if the liver is bleeding, and it's actively hemorrhaging, as long as the patient is semi-stable, we'll try to do IR so that they can embolize that little branch so that we don't necessarily have to go in and again try to pack the liver that's fractured. Okay. Which solid organ is most frequently injured in blood trauma? Guys?
The liver.
Liver, thank you. Alright, so when we're grading livers, okay, there's 6 grades. Thankfully there's 6 grades to the spleen and the kidney as well. Okay. So when we have a grade 1, it's just a laceration, a tiny little laceration, less than 1 centimeter, or a little subcapsular hematoma. It's still within the contours of the liver, but it's less than 10%. Okay, that's grade 1, very minor. Grade 2 is you have upwards of a 3 centimeter lacerations, 10 to 15% of a subcapsular hematoma, or less than a 10 centimeter intraparenchymal hematoma. Okay, and just progressively get bigger, and then when we have a grade 5, okay, this is 75% of the hepatic lobe disruption, and or it goes through the major hepatic vein injury. Okay, these are big, like catastrophic. Grade 6 is a catastrophic liver injury. It goes through the huge vessels and vasculature of the liver. It's very hard to maintain, very hard to fix. Okay. These are almost, the high mortality. And they're very hard for us to fix. So repeat imaging in asymptomatic patients is really, we don't really know if we're going to do it. We're most likely just going to do an ultrasound to see if there's any bleeding or any hematomas, if there's if the fast goes to then positive, then we'll do a CT. Okay. Looking for that right upper flexion or right upper quadrant glute flexions. Okay. In asymptomatic patients who have a already confirmed high grade, so grade 4 and above liver injury, we're not going to just dig around with an ultrasound. We're already going to just get a CT on the pelvis, or at least a CT abdomen. Okay. We want to try to exclude any delayed pseudoaneurysms. We want to try to figure out if it has become a abscess necrosis. It's just a retained hematoma or myeloma. Sometimes it's hard to tell between all of these things until we try to drain it, but we're not going to necessarily drain these right away. This is going to be, month 1, month 3, when we kind of see them and follow up. If they have retained anything, which I've seen before, right? If they have, 75% of their, or even 50% of their liver is now a hematoma, that's most likely going to become a abscess, right? Unless it's blunt, like especially if it's penetrating, they got shot, they got stabbed, right? Those are not sterile instruments, not sterile things. Most likely it has introduced bacteria into that hematoma. And so now they're at a higher risk of getting an infected hematoma, infected abscess. I had this kid who had a gunshot wound to the liver, and he was my patient for like 6 months off and on because he just kept having this horrible necrotic liver. Okay, so he would come back every so often to get a new drain placed to see if we could drain out that abscess. He'd be admitted, probably antibiotics, then he'd get better, go home, and then it just repeated for like 6 to 8 months. It was crazy. Documented healing, so that when can they get back to, the routine activities? When can they, go back to contact sports, okay? If they have a high-grade injury, it really should be re-imaged at 3 months prior to return, okay? Because we want to make sure that this didn't happen, okay? And then post-imaging, 4 to 8 weeks, probably not for grade 1s, but anything that has a significant, probably grade 3 or greater, we'll do some sort of imaging, whether it's an ultrasound or a CT scan at 2 a month or 2 after their injury, just to make sure that they didn't develop any pseudoaneurysms or abscesses within their injury. All right. Spleen. Now let's take a 10-minute break. I know it's Monday. All right, so going back into it, so the spleen, right? So we did the liver, now the spleen. So it is a very commonly injured in blunt. It's not the most common if the liver is, but historically it does have a pretty high mortality rate, like 10% mortality rate if the spleen is injured. Okay. Those are the different types of mechanisms of injuries we can see with it, but really anything, penetrating, blunt, all of it can actually hurt the spleen. Okay. Stab wounds are a little less likely to cause any spleen injuries because the spleen is still kind of fluid and movable a little bit. So sometimes it can kind of move out of the way with a knife versus a gunshot wound or and all that. So up until about the 1970s, the splenectomies were the mainstay of treatment. Our medical advances have really strong leaps and bounds, and so that we don't necessarily have to do that as much anymore. There's a lot of things we can do in terms of just observing, because now we know, like, if it's a low-grade spleen injury, it's not going to necessarily lead to much, versus if it's a grade 5, we can potentially just embolize that artery and vein and actually not have to take the spleen out, but it's effectively a splenectomy. Okay, the spleen is no longer getting any blood, and so it'll die in the body. It'll calcify and kind of reabsorb whatever. But there's a lot of things that we can do now in order to not have to go through an actual splenectomy. So initial evaluations. Okay, penetrating with hypotension or peritonitis. Okay, we're going to do an emergent laparotomy. Okay, just like with everything else. Stable patients with stab wounds will undergo further evaluation. We'll get a CT scan, okay, and kind of see what's going on. If it's a gunshot wound that traverses the peritoneum, right? If it's a transabdominal gunshot wound, we're going to do a laparotomy. In blunt injuries, if it's a positive FAST plus a hypotensive patient, should prompt emergent, right? It's that unstable, hemodynamically unstable, that really determines whether or not we can do other things like IR versus having to go in and do an XLAP. Okay. Stable patients who you know, are kind of in that intermittent thing. We really need to do a CT abdomen pelvis with IV contrast to really like diagnose the extent of the injury. Okay, and if the spleen is too damaged, needs to be removed, then that's called a splenectomy. Okay. These are the spleen injuries. Okay, all the way 1 through grade 6. 1, again, little laceration, less than 1 centimeter, subcapsular hematoma, less than 10%. Okay, same as the liver, right? All the way up to, you know, grade 6. Okay, you have this doesn't go up to grade 5. Hold on. Oh, this is 2 grade 3s. So this is showing. This should be. Hold on. The pictures don't necessarily correspond to the words. I'm sorry. I did not catch that last semester. So the picture is showing 3 is 2 different types. But realistically, if you go by the words, that's a little bit better. Although there is, you know, that grade 5. Maybe on those. Anyway, the worst grade, okay, will be grade 5 for sake of the PowerPoint. That is either the hilum is devascularized, so an injury that is transecting the splenic hilum, okay, or the spleen is just shattered. Right, it is a completely shattered spleen. There's no way to put it back together. It is in a million, you know, multiple pieces. There's no way of trying to repair it. Okay, at that point, once we get to grade 5, then we can either do an IR embolization if they're stable, to just, you know, embolize the artery vein, to not have any bleeding, is basically ligation, internal ligation. Or we can go in and take that spleen and try to get as much of that spleen out. Alright, moving on to the kidneys, right? We're looking for that gross hematuria, flank ecchymosis. We're looking for nausea, vomiting, any abdominal distension, okay? Again, penetrating injuries with hypertension, peritonitis, right? We're going to do an emergent XLAP. Stable, most of the time they can, with a stab wound, we can undergo that CT abdomen pelvis IV contrast to kind of really delve into what is actually injured and how much. Again, gunshot wounds that traverse the peritoneum are going to go to laparotomy. Blunt, again, kind of same picture, right? If it's stable or if they have a positive FAST and they're unstable, we're going to go straight to laparotomy. If the kidney is too damaged, that is called a nephrectomy, is taking out one of the kidneys. Okay. All right. And again, grade 1 through 5. Okay. You know, a little bit of a non-expanding hematoma, maybe a little 1 centimeter laceration, and then all the way to either a shattered kidney or the hilum to the kidney is destroyed. Okay, at that point, there really isn't much embolization we can do. We can a little bit, but because of the renal pelvis, if the ureter has been, you know, transected, then we really need to go in and fix that. There really isn't much of a IR embolization that we can do for the ureter, and we don't want a uroma that can happen if the ureter is injured, and then it's, you know, all of that urine is just kind of spilling out into the belly. Okay, so if the ureter is injured, then we have to go in and do a nephrectomy. Okay, moving on to pancreatic and duodenal injuries. Okay, they can be very subtle. They are retroperitoneal. Okay, they're not frequently injured, but we do have to have that high level of injury, because if we miss these, again, the complications can be pretty dire. Okay, gonna pay attention to like their history: a direct blow to the epigastrum, a bike handle, a you know, skiing pole, a motorcycle handle, you know, whatever, and that they have anything that directly went up into the epigastrum, then we have to automatically think, okay, did they enter their duodenum and the pancreas? Okay? If they have, you know, it can lead to anyway from like frank peritonitis to just big abdominal pain, you know, a little bit of back pain, maybe a little flank pain, maybe just they're anorexic, they're just not hungry, they're a little nauseous, all the way to, you know, maybe they have some lower spine fractures from that force. Okay? Alright, 17-year-old suffered blunt abdominal injury following motorcycle collision. This x-ray, abdominal x-ray reveals air and fluid in the right perineal space. He was rigid, distended anterior abdomen was structure is most likely injured. Who wants A, B, C, D, E? Okay. Duodenum, right? So you have air and fluid. That air means it's got to be a polyviscus or some sort of organ that has air within it. Alright. So, no real laboratory findings for a duodenum or a pancreas injury. If we suspect it, we're going to get an amylase. Okay. If they do have amylase, amylazeacia or hyperamylase, okay. It's not a reliable indicator, but it should heighten our suspicion for pancreatic injury. Okay. So if they do have high amylase, then we're going to do a CT IV contrast. Okay. Again, it doesn't necessarily mean that there's a pancreatic injury, but it heightens our suspicion even more. Okay. So plain radiographs, again, you know, we can see that retroperitoneal air, pre-interperitoneal air, or obliteration of the psoas shadow. Primary diagnostic modality is going to be that CT published with IV contrast and PO contrast. We need to have that PO contrast so we can see the duodenum. Okay, we need to see if it extravasates out of that duodenum anywhere within the epigastric region. Okay, what type of PO contrast are we using? Water soluble. Okay, it's like iohexol, Omnipaque, gastrografin. Are we using barium? No. Right, because we're already suspecting that there's probably a solid order, viscous hollow organ injury. Right, we don't want to put barium into the belly. Okay. You'll probably see, so if there is a duodenal or pancreatic injury, okay, you're going to see that retroperitoneal air, maybe that contract extravasation, fat stranding, unexplained fluid, or just duodenal wall thickening, right? If it's thickened, that means there's inflammation, inflammatory process starting to happen. You can suspect that there's some sort of injury there. Okay. If clinical suspicion still remains high after a negative CT, okay, then we admit them, we do serial abdominal exam, and then we repeat their imaging within a certain time frame. Okay? We don't let these people go home, because if we miss these, it can be like if pancreas starts to spill bile into the belly, like that's a digestive enzyme, right? Think of the digestive enzyme and how it's going to react to the rest of the external gut. It's going to digest it, right? It's not going to be good. It's going to be really bad. So a lot of things can happen, so we don't want to miss these. Alright, patient falls while skiing. Ski pulls injured her mid-abdomen on arrival to an emergency room. She's in severe pain. Examination reveals ecchymosis, rebound tenderness. Suspected to have pancreatic injury. Blood pressure okay. Heart rate okay. What's following is the best diagnostic study for her suspected condition. Is she stable? Okay. What's the question asking? Diagnostic study. Okay. We think of pancreatic injury. What is going to show us pancreatic injury? Who wants A? B, C, D, E, CT. Everybody know what diagnostic peritoneal lavage is? It's a very old technique. If you see it, don't get distracted by it. You don't use it anymore. Although at my hospital in Cook, they said that they did. It was still part of their algorithm. But the 2.5 years that I was there, I never saw it get done. Basically, what it is they instill the belly. It's like the poor man's CT to see if there's blood or fecal material inside the belly where it's not supposed to be. So they basically make a little incision around the umbilicus. They instill a bunch of like 1 liter of like LR into their belly. They let it sit for a minute and then they drain it. And then they take that, unless it's like frank blood or frank like food material, right? They're gonna send that off to psychology and actually see like what the blood count is and what that stuff is, and if it's positive, if it's above, I think, I don't even know, probably 100,000 per field like red blood cells, and it's positive DPL, and then they know that there's some sort of injury in the belly, and they will go and do an X-lab. It's already frank blood or gross blood or food, then they know that there's an injury, and then they'll go and do an X-lab. But we very rarely do that. You may see if you ever get deployed and you don't have a CT scanner, that is still part of like the JTS because it is a way of like telling, but again, not really used in modern technology now. All right, moving on to pelvic trauma. Okay, so pelvic fractures can be associated with significant hemorrhage. Okay, really, if you have other parts of the body that are seriously injured, you have to suspect pelvic injury. Most of the time it's going to be arterial, but when I say it's probably venous, okay, remember that on the anterior surface, the sacrum, you have that posterior venous plexus of the pelvis. Okay, when you have major pelvic injuries, it's not just the anterior, but it involves the posterior. That's when you have destruction of that venous pelvis, and that's why putting a pelvic binder on closes that down and kind of knocks it off. So most likely it's going to be venous, but it can, because there's a lot of vasculature, a lot of arterial, big vessels in the area of the pelvis, you can have significant arterial bleeding. You can actually get 4 liters of blood that can accumulate in the retroperitoneal space. Okay, that's when you only have 5 liters in your body. That's bad. Okay. All right. So when we do an evaluation, again, we want to do that manual compression and distraction of the iliac crest. Okay, we're looking for abnormal movement and or pain. If it's positive movement, positive for pain, we can't rule out a pelvic fracture. And most of the time we feel spine that you do have some sort of a pelvic fracture. Okay, you can either do a prefabricated splint, meaning a pelvic binder. We have the SAMs. There's a bunch of prefabricated ones out there, or the poor man's one is just taking a nice sheet, wrapping it around really tight, and then clamping it to each other so it stays together. Okay, you want to try to wrap the legs together. Try to induce some internal rotation because that kind of pushes the pelvic wings together as well, trying to close down that space if you can. Okay. When we have any sort of pelvic fracture, we want to inspect the genitalia in close detail. Okay, we don't want to place a bladder catheter. If we have any blood at the meatus, if there's a scrotal hematoma, if there's any blood on the GRE, or they have high-riding prostate. Okay, we want to perform that RUG, that retrograde urethrogram first. Okay, before we want to make sure that the urethra is competent to actually be able to accept the Foley before we make it worse. Okay, and then we do a cystogram at the end. And then for female, again, this is where, when you're inspecting genitalia, I know this is a lot of male stuff, but we still want to do a vaginal exam too. If you have, any anterior pelvic fractures, especially if they're, shattered, Those can very likely go into the vaginal canal and actually lacerate the vaginal canal and cause a lot of issues as well. I think I have a slide on that in the future. All right, so hemodynamically unstable patients, you do a fast real quick. If the fast is negative, pelvis is most likely the source of bleeding. Okay, you want to try to figure out if it's arterial, if it's venous. Do we want to go to IR? Do we want to go to the OR to either do like pre-peritoneal packing? And that is basically you do a lower, if we're not going in to do like a true XLAP, we're going to do a lower incision, still above the, it's basically the lower half of the XLAP. And we don't actually go into the belly, okay? We don't go in through the peritoneum. We try to separate it, and then we pack really low down right above the psoas. So we're actually like kind of going around the belly and into that retroperitoneal space and packing that off on both sides, trying to pack and put compression on those iliacs, okay, from the inside. If they can handle it, we'll do CT, abdomen pelvis, again, IV contrast, plus or minus PO or PR, depending on what we're looking for, what the mechanism of injury was. Only if the patient is stable enough though, right? This is, you know, if they do have extravasation of media or the contrast, you have a large retroperitoneal hematoma, or abrupt cutoff of an artery on the CT, then we'll most likely get IR involved first, have them do an angiogram and embolize whatever they need to before we go in and try to do anything. And then any patients with an unstable pelvis fracture, okay, with venous hemorrhage, we will try to do that external fixation, either the splint, or we'll have ortho put on an external fixation device as we talked about. All right. So again, we're evaluating for that hemorrhage. We're trying to stabilize the pelvis as much as possible, either doing that pelvic binder with the sheet, or we can do an external fixation with ortho. Okay, we want to, if we confirm that there's a urethral injury with that rub, okay, we're going to consult urology for them to do either a guide wire type of placement of the Foley, or they'll just go in and do a suprapubic urostomy. Alright, so penetrating this transpelvic trajectory, okay, this requires a full workup of vaginal exam, DRE. We need to do a CT pelvis with that triple contrast. We really need to evaluate that sigmoid and the rectum, okay. More than likely will require an XLAP. There's been occasionally where it just kind of goes in and hits the bone, or maybe a butt shot, and you know, it just kind of bounces off the pelvis, and the pelvis is broken, but there's nothing bleeding intrapelvisly, like intrapelvis. So you know, we could theoretically do non-operative management. It just really depends. Okay, like this one, you have shattered iliac crest. Okay, there's a little bit of bleeding around that psoas here. Okay, iliac crest, psoas, a little bit of bleeding there. Doesn't look like the same as over here. Okay, so you can probably go in and do that. This next one, you can actually see the trajectory of the bullet going through the pelvis. Okay, and then here, you can actually see, so this is where it kind of comes in, and most likely, like, you don't really see a lot in here, except you see the posterior iliac crest, or PSIS is fractured, and you have some bleeding around the colon. Alright, we're BOA. Okay. You'll use these more so pre-hospital, or sometimes, depending on your Roll 2s, sometimes they'll have them if they don't have any real surgical capabilities. So what this is basically, it is a internal aortic, like, think of it as an internal cross clamp, right, of the aorta. Okay, there's different zones in which we can expand this balloon inside the aorta and effectively cut off the rest of the like blood flow post that. Okay, so if we have a bilateral amputation and we can't get control because it's super high, theoretically we can put in, if we can at least get to the FEMS, we can put in this Reboa and actually do it lower in the zone 3. It's below all of the gut vasculature, below the kidney vasculature, and basically it cuts off all blood flow to the rest of the legs. Okay? It was like an internal tourniquet kind of thing. We really don't do zone 2 because there's way too much vasculature there. So we go to zone 1, and that is around the diaphragm. Okay, it's like the distal thoracic aorta before it turns into the abdominal aorta, and this has a very high mortality rate. Because think about it, if you have that up for more than even an hour, right? Your gut's not getting blood supply, your kidneys aren't getting any blood supply. All of the stuff post that balloon does not get any blood supply. Right? So some people love it, some people hate it. I have been taught how to do this, but I've never actually used it because if we're suspecting that we need to, clamp off the aorta, we're just going to do a thoracotomy and clamp off the aorta. Right? So it really just depends on where you are in order to actually know if you need to do this or not. Okay, read that. What do you guys think? What's the best initial treatment for the patient? Who wants to do a pelvic binder? Anybody have any other suggestions? Good, pelvic binder is. Good. Alright, post-operative complications, ACS, okay, abdominal compartment syndrome. This is nowadays pretty rare with the advances in medical technology that we have in order to leave the belly open for an extended period of time. But after a long abdominal case with like a lot of manipulation within the bowel or trauma, or if they needed massive fluid resuscitation, okay, and the belly and the fascia, like the actual fascia, doesn't matter if the skin's closed or not, but the fascia, that really tough connective tissue, right, if that's closed, think of that as like the belly is now a compartment under pressure, okay? So what does it do? What does it lead to? It actually increases peak airway pressures, okay, which then decreases your cardiac output, increases your systemic vascular resistance, okay, and can really compromise, your cardiovascular system, right? It really can compromise it. So, if we do close the belly, we do a lot of frequent checks to make sure that there's no increased acidosis, that their urine output is still adequate, and that there's no increase in lactate. How we can prevent this, right, is if we have had a long abdominal case and the belly or the intestines, are really edematous, okay? There have been some times at the end of a long, trauma case that they've kind of taken both sides of the belly, and each of the providers on each side kind of pull it closed and then watch for the peak pressures with the anesthesia. And if it starts to rise, then we're like, okay, they're not going to do well, so then we leave them open. Okay. If we do end up closing and they end up having increase in this abdominal compartment syndrome pressures, then we're going to do a deep compressive laparotomy. We can do this at bedside as long as they're sedated and intubated. Otherwise, we'll take them emergently back to the OR. All right. types of other postoperative care. These are 2 types of drains that we sometimes leave within the belly. Okay, it'll help with, we know we have a pancreas injury, or we had to take their spleen, okay, and the distal pancreas may be leaking a little bit. We'll leave this Jackson Pratt drain. It's a flat perforated drain. Okay, so at the top, okay, it's flat. And it goes, the white part is inside the belly, and then the tubing runs to the outside with the grenade. There's a bunch of different types of collection tubing for collection things that we can use, whether it's a hemovac or the grenade that you see, or it's just a gravity bag, not under pressure. Okay, but those grenades actually we can you know, clamp down or push down a little bit and cause this type of very mild type of positive pressure, well, negative pressure, kind of like that negative wound vac, right? But it's just within the bulb. Okay, so if there's not a great seal around that bulb is just going to continuously pop open, and it's more to grab you than actually trying to pull out that fluid. Okay. Now, Penrose is just a long rubber tube. Okay, it is not under suction. It doesn't go to any gravity. If we have a big long incision or a long wound that you know, is at risk of getting infected, and we want the inside to heal sooner rather than the outside, then we'll place this drain kind of in the wound, close up around it, and that way the wound is actually can drain around this tube. Think of it just as like a placeholder to keep that wound bed open, so it can kind of start to heal from the inside out. Kind of hard to picture it in your head. I'll see if I can find some pictures later if you guys want to, but like this is not under pressure. It's literally just to keep the space open. We normally suture it to the skin so it can't come out, but it's you know, we can cut it as short or as long as we kind of need it to be. We can loop it around and actually tie it at the ends or suture it at the ends so that you know, it doesn't come out. But it just allows that drainage from the wound bed. Okay. All right. Read that scenario. What do you see? Seatbelt sign. What else do you see? Or read? Stable. Yep.
Primary service, ID access, captain control.
Yep. So what do you want to do next? What can you do before CT? Fast. Right? You want to do it because he's stable, right? So you do a fast exam, looking for any intraperitoneal type of injury. What if the fast is negative? Do you need to go CT? Potentially no, right? Although given highway speeds and with the seatbelt sign, most likely he's going to end up in the CT scanner. But if the pass is positive with a positive seatbelt,
Slap.
you know, sometimes we don't need to even go to the CT scanner. We will, but it really just depends. But yeah, fast, and then if positive, maybe OR. If it's negative with stable hemodynamic stability, then we can go to CT scanner. If the CT scanner is negative, then we can go to Fluorocarbon. Right, do serial calculations. Does that make sense? What about this one? What do you see? Seeing, hearing, open them up, okay. So you have a GSW, hearing umbilical, that's transabdominal, right? 15 minutes ago, you have abdominal pain. Although the GSW is hemostatic. Vital signs, are those normal vitals? Not great, right?
Great.
Not great. Diminished physical pulses, no other injuries, you have IV established. You gave him some fentanyl. What do you want to do? I'm hearing XLAP. What do you want to do before XLAP? Well, the OR is getting ready.
Antibiotic.
No. That's part of the pre-op stuff. So you have one hole. Alright. You're gonna roll them, sure, but there's no holes on the back. So you're gonna go straight to XLAP? What do you gotta try to find?
CT to find the bullets.
This is the one case in which we absolutely have to get the chest and x-ray. Right, we need to know that there's only one missile in there, and that we're not missing a second missile or a second injury, right? Especially while, I mean, the OR takes a minute, right? It takes about 20 minutes, 10 to, theoretically, they could, if we needed it, they could open within 5 minutes and we could start cutting. But we do theoretically have a little bit of time, right? He's definitely needing to go to the OR, but we still want to try to get that chest and pelvis x-ray just to make sure that there's nothing else going on before we take it to the We have already a plan of, yep, there's one bullet and it's right next to the spine, or it's, you know, we think it's next to the kidney, or hey, we now found two bullets, two missiles within the belly. Then we gotta start looking for that third hole, right? What if we find no bullets? What did we miss? Alright. Another hole, right? If we have one hole and no bullets on imaging, then we're missing a hole. Remember, bullets plus holes have to equal an even number, or else we're missing something. Alright? Alright. So, review, you know, blunt trauma may or may not need surgery. We're really looking for that liver, spleen, or even renal injury. If the FAST is negative, right, we can observe, especially if the CT is normal. If it's positive, FAST is positive, we go to surgery, okay, especially if they're unstable. CT negative, observe, positive, we go to surgery, or observation depending on the grade of injury. Penetrating, hemodynamically unstable, we take the OR. Now, we don't delay surgery for a faster CT, okay? We don't blindly probe a wound in the ED, okay? But if we can, like if this guy, right? If this guy, we already know his FAST is going to be positive. He got shot right here, okay? Unless it like tangentially went, you know, and went here, he wouldn't be unstable, right? So we can already, you know, say we don't even need to do a FAST on this guy. We already know he's going to have blood in his belly because he got shot here and he's unstable. So we can get a quick X-ray of abdomen and pelvis, see where those bullets are, and then go to the OR. Now, have we gone to the OR without having a chest and pelvis X-ray? Absolutely. But if we can, you know, if there's time for it, we still try to, so that we have some sort of picture of what's going on inside the belly. I was going to start the head trauma today.
You would what?
I really don't want to do only 10 minutes of it. So, we're good.